let's talk about airway. Airway is something that I didn't expect to get into when I started orthodontics. I didn't go into ortho to become a physician or an ENT, but it's really important. And what I've learned about it has really transformed my practice. As I mentioned earlier, most patients that we thought we were going to look at their airway, we thought they would look like that, but a lot of the malocclusion patients have airways that look like this. The problem is many of these patients with airways like this sleep like this. That's one breath. Two breaths. Imagine being this little boy's body and trying to recover and rest and grow your brain and grow your musculoskeletal system. That's torturous, and kids should not have to do that. And orthodontists are often the first line of defense when it comes to breathing issues. So I want to encourage you to think of airway not as, oh, what's too big, what's too small. I want you to think of it as really identifying children in trouble. Now here's what we do all day, every day with our two-phase treatment. This is a typical case for us. This is Macy. Here's where she started. Class 2, Division 1. She actually has a little spacing between the incisors, but we expand her because she's narrow and she needs it. This is what she looks like pre-phase 2. And here's her phase 2 records. Nice occlusion, nice smile, nice aesthetics. 2 phases separated by a very long break, but we think a very nice, stable result. 10-month phase 1, 15-month phase 2. This is what her airway change was like. MCA is what we call minimal cross-sectional area. She went from an MCA of 42 to one of 159. Do we care? Maybe. This paper is the best we have in terms of norms or what's a normal airway for a kid. And this is by Schendel and his group from Stanford. And what they did is they measured the MCA, minimal cross-sectional area, on 1,300 individuals at various ages. And what Schendel and his colleagues found is that from early, 6 years old, up to 20, MCA increases. So even without any orthodontic treatment, airways get bigger. That's great. They usually increase about 10 times your age. So if you have a patient that's 8, and their MCA is around 80, that's kind of normal for Schendel's group. So the problem is, as we get older, it goes the other way. So past 20, your airway gets smaller. And if you get unhealthy or you gain a little weight, your airway becomes even smaller. So this is where adults get in trouble with obstructive sleep apnea. This slide I borrowed from my good friend Dave Hatcher, and you'll notice that there's this high-risk group of anybody with an MCA smaller than 50, high correlation with obstructive sleep apnea in adults. 50 to 100, moderate risk, moderate correlation. 100 to 150, low risk. Anybody above 150, they did not find any demonstrable risk or any demonstrable correlation between MCA and OSA. Now remember, correlation and causality are very different things. This is simply saying smaller airway, higher correlation with OSA. So here's what happened for Macy. What I'm putting on this top bar is this is where she should have been, quote unquote. This is the standard relative to the Schendel paper. So she started at 8 years, 9 months. Her airway MCA should have been 89. She was at 42. Following our treatment, she went to 160. Might be an individual change. Great, maybe she just grew really great, we don't know. Here's a sample of 26 consecutively treated two-phase cases. The top is the Shendell average again. The middle bar is our sample's average. And the lower bar is what we call the median, which for those that know statistics, know that if the median is close to the average, you have a relatively normal curve. So here's what happened after phase 1. Notice that the median trailed a little behind the average, but it stayed pretty close. We still have this whole normal curve moving up. Already surpassed what Shendell says as normal. Here's what happened after phase 2. Now there were some laggers and there's some outliers, and that's important to note. But when we're getting 2.5 times change relative to what we see on average, that means to me that we're developing airways. Now, I'm not saying we're curing OSA. OSA is a very complex disease that is far from just one number. So just because you have an MCA that's 219 does not mean you will not have OSA. And just because you have an MCA of 40, that does not mean you're going to have OSA. This is complex. But if I'm a betting man, I want the biggest airway for my children as I can get, knowing that this is a soft tissue space that is prone to collapse. The bigger it is, the more space it's going to be there when it does collapse. But this is what that snorer was having the problem with. Adenoids and tonsils, we pick up all the time. And we're sometimes the first to pick them up before the pediatrician. And this is really important because when you have adenoids and tonsils this big, you sleep like that kid I just showed you. And this is a study that looked at adenoids and tonsils removal and how much it changed sleep quality. So I'm just going to focus on what's called RDI, and all that means is the quality of sleep, how much you're waking yourself up, how much you go hypopneic. And so what this study did is they had a group of patients that they divided in half. And the first half got an expander first, and then a sleep study. And then they got their tonsils and adenoids out, and then another sleep study. The second group got the opposite. They got the TNA first, and then the expansion. So the nice thing is they were able to change the sleep pattern from an RDI of 21, which is really high for a child, and get it down to 1.6. That's a life changer. But what I'm interested in is for the ortho group, the patients that just had the expanders first, no TNA. You'll notice that the RDI changed from 21 to 8, 7.9, just expansion. So just getting that upper jaw to a better width is improving sleep. So this is really taking those hypopneic apnea events and cutting them down dramatically. 60% decrease in RDI. This has nothing to do with MCA. I want you to get that point. This is about how much these kids were not breathing at night. 60% increase in breathing quality or decrease in RDI from just expansion. When you added in the TNA, 90%. Massive. Life-changing.